Okay, welcome to this lecture series or the graduate courses for nuclear medicine or graduate course for molecular medicine and biopharmaceutical sciences. We have three different groups of participants here. This is the continuation of the lecture series, which started last year, the same similar time, around September, partly because of the COVID-19 pandemic crisis, and also the by the support of the European Commission or European Union, which is propagating research, National Research and Education Network to facilitate and promote medicine, science, engineering, and social well-being of the Asian countries, which had supported until this semester. And we are going to start another project, continuing project, supported by Trans-Eurasian Information Network, PAIN, or Asia Connect, this next year, and we are going to submit full proposal. So this lecture series, PAIN lecture series, has participants from at least 6 countries, and next year we are going to promote this lecture series to Nepal and also Mongolia, and hopefully India and also Philippines. So you might expect 6 countries, more than 30 institutions, and around 50 participants from abroad. And we have organized, we meaning I and Professor Seo, Min-Seok Seo, is my close colleague, and he and I organized this lecture series a 3rd time. And maybe next to the next, he would be the sole organizer of this, coordinator of this lecture series, if successful. So he had received the wish list from the previous participants from 3 to 6 countries, meaning mainly Bangladesh, Indonesia, Vietnam, and then Thailand, Malaysia, and also Myanmar. So here you can see during the October, the topics covered are going to be a little bit beyond brain, meaning diagnostics using FAPI, correlative imaging of lymphoma, hepatoma, and PSMA diagnostics, current progress. Those issues were chosen from the recommendations or advices from the previous participants. And I'm happy to say that in this lecture series, mainly focused on brain, in addition to the meeting the wish lists from the participants, so mainly focused on brain. So I have successfully, and they kindly, they accepted my invitation, my and Professor Seo's invitation regarding the lecture participation, who are the best experts in this country. Professor Yu Jung Kim, she's going to talk about the Alzheimer disease and the application of radiopharmaceuticals or nuclear medicine methods to handle the Alzheimer's disease twice, today and the next week. And also we have best experts in this country, measured in Parkinson's disease. So September the 15th, you can listen to the lecture by Professor Kim of Asan Medical Center. Asan Medical Center is affiliated with Hyundai Motor Company, motor car company. And his ex-student now, the young professor, Professor Sun. And then during the lecture slots, mainly focused on the cancers, and we have graded course for this lecture series is also the graded course lecture for the molecular imaging for clinical future clinical trials, and currently 10 students, including one foreign student whose native tongue would be maybe something. However, his second the language would be fluent English. So this lecture series is entirely in English. And that molecular imaging for clinical trials, that course lecture during the October, you can expect the participants, 9 Korean students and one foreign student. You might expect the lectures from by a adjunct professor of this department, Professor Yuri Choi, who has a laboratory here in this Yangon campus. I mean the medical college campus, College of Medicine campus, and she's going to give her lecture during October. So she needs to move from this the account. What I mean is a Zoom account is going to be different during October for those 10 students. However, a student has registered a nuclear medicine graduate course. He is a resident here in this Seoul National University Hospital. So Dr. Kil, you might just continue to stay here from September 1st today to December the 1st. And those students who registered officially in the graduate course, they are going to have no midterm examination, and they are going to have a term examination in December the 1st, which is going to be also online, email type. So let me introduce Professor Yu Jung Kim. Has she logged on? Yeah, so I can see her face. Professor Yu Jung Kim. She was chairman of the nuclear medicine in Seoul City Metropolitan Hospital, and also she's a professor in College of Medicine, Seoul National University since long ago. Her major is, as I told you, is in the brain nuclear medicine. So she kindly accepted my invitation. She's going to use her 2.5 hours today for a meeting, and 2.5 hours next week on Wednesday regarding biomarker. We've listened to her lecture during morning conference, lasting only 1 hour each. And we were really impressed, and we meaning all the participants were really impressed, and we learned a lot. And we were also eager to listen to the more stories. And then these topics are so important. So her lectures are going to lead the entire lecture. And as is here, This is here, listed here on the left side. The last lecture of this lecture series is going to become the instrumentation and analysis method by a physicist, and who has recently made his own brain PET machine, which is going to be cheaper than the current one, and Professor Jae-sung Lee. And then during winter workshop, he is going to continue a workshop series twice for 6 plus alpha countries, and during January and February. You might just expect best from this lecture series and also the next workshop. And Professor Yu Jung Kim, please. That was the introduction.
So, hello. So,
yes, we can listen to you very well.
Yes, can I, okay.
Yeah, share, please.
Okay, can I see the imaging?
Yes, sure.
Hello, my name is Yu Jung Kim, as already Dr. Lee introduced me, and I'm working in Seoul National University, so Metropolitan Government Hospital, which is a public hospital, and we are treating so many Seoul citizens as well as foreigners. Today, we're talking about amyloid and tau imaging in Alzheimer disease. Actually, I am not alone about the use. You have an experience of the amyloid and tau and brain imaging in clinic. So, so without knowledge, so I just briefly lectures from the basic to the clinic. Yeah, okay. So when a patient with memory problems, the doctor, what the doctor have to do? They have to decide the possibility of possible Alzheimer dementia or the probable Alzheimer dementia, or they have to decide that the memory problem can be from the other disease. So the doctor have to do to diagnosis of Alzheimer's disease. The first thing is listening the clinical history. They may ask about the symptom from the person or the family or the caregiver. And then also they have to get the test, because the test may have the subjective evidence of the memory problem, and then they have to do some kind of a study to identify the other cause of the problem, such as medical test and in imaging. And in the past, during the kind of result, they decide possible Alzheimer's disease or problem Alzheimer's disease. However, recently we have to do that have to unbiased classification of the Alzheimer's disease, because medical history and then some kind of neuropsychological test sometimes that reproducible. So we have to more confident evidence and unbiased evidence. So the NIA recommended the ATN guideline, and then they means amyloid tau neurodegeneration-based amyloid diagnosis, Alzheimer diagnosis. So for the Alzheimer diagnosis, amyloid and tau is major pathology. For the Alzheimer diagnosis, the major pathology was included in the diagnostic biomarkers. For the measuring of amyloid, they used the CSF marker or the typical amyloid PET, or the tau amyloid mark also used the CSF or the imaging. With the imaging of with the biomarker of amyloid and tau, they have to classify the amyloid positive and amyloid negative. And then if amyloid positive means Alzheimer-related disease, if amyloid negative, that is not amyloid. So current dementia or the memory impairment usually classify the Alzheimer continuum and non-Alzheimer disease pathologic change and the normal Alzheimer biomarker. Comparison with CSF biomarker, PET image is very simple. So we have to just the injected radiotracer and get imaging. They have a less side effect than CS biomarker. So currently we use the PET imaging for the biomarker of amyloid and tau. Before amyloid imaging, we have to tell about the FCG Path. ATN criteria, FCG Path can measure the neurodegeneration of the Alzheimer's disease. Actually, the FCG Path is used for glucose metabolic change. And then so the brain imaging was already done in the 19th centuries. So when we diagnose of Alzheimer's disease, the sensitivity of the FCG Path is more than 90%, and the specificity is 86%. If you can see the imaging of the Alzheimer brain, the FCG Path shows decreased regional metabolism, and then also particularly involved in the parietal cortex and temporal cortex and the frontal cortex. Usually the topographic finding was like that. The symmetric distribution of the parietal cortex, posterior cingulate area, and temporal cortex shows the hypometabolism. Progression of the neurodegeneration also reflected on the FCG Path from the normal healthy elderly to the advanced Alzheimer's disease, progressively decreased the metabolic activity in the cortical region is associated with their cognitive function and then reflect their neurodegenerations. The pooled data is highly good diagnostic accuracy using the FCG Path in development of Alzheimer's disease from the MCA patient. Actually, the delayed cross-sectional study predict AD conversion from MCI. The sensitivity and specificity is around 90%. If we collected only amnestic MCI, which is a typical MCI, and they predominantly go into the Alzheimer's disease, the conversion rate, specific predictive accuracy is more than 90%. So FCG Path is traditionally used for management of Alzheimer's disease or pre-dromal Alzheimer's disease. In Korean study also similar sensitivity and specificity, and then so we pulled the data shows the sensitivity is more than 90%, and the likelihood ratios is around 7. Now let's move to amyloid PET imaging. So for the brain imaging, the radiotracer should have the common characteristics. In case of the imaging of amyloid PET, it also has the same characteristic for the brain imaging. The first of all, we have to get the radiotracer have high sensitivity and the specificity for the binding target. And in case, so we have to specificity for the amyloid detections. And also it has to be high contrast. And that means we can detect low level and change of amyloid burden. And also, so in the use of, for the use of the clinics, so we have to get the easily, and we have quite easily the radiotracer, and we get the easily get the image of the radiotracers. So we have to reliable quantification method, and for the imaging, so we have to the radiotracer is better having short imaging time. And then also good reproducibility is an important thing. So for the imaging of the amyloid, it was originated the theophylline T, which is a classical chemical staining agent for the amyloidopathy. You may know about the PIB. PIB is a gold standard for the imaging of amyloid PET in vivo. From the PIB so there is lots of the several amyloid tracers. Some are already approved by FDA. Some are currently developing. They has 3 FCG approval radiotracer for amyloid imaging: flutometamol, clobetamol, and the amyloid, flupitabir. They have moderate lipophilicity to enter the brain, and also they have the good sensitivity and binding potential for the amyloid. And then the brain uptake is moderate and good for the imaging of the brain. And brain clearance is important when we get the imaging, and when we how we get the clear imaging. So this radiotracer is get proper characteristics. So the Amyloid is the first radiotracer to get FDA approval that has commercialized by Amyloid. They provide negative scan and positive scan. And when the first, when the time of release, they give the indication and the uses for amyloid scans. In the cases of a negative amyloid scan, that means there is a sparse or no amyloid plaque in the brain. But that means it can be the likelihood is high when the patient cognitive impairment is due to Alzheimer's disease, less high. The positive amyloid scan is abundant amyloid plaque in the brain. So the positive amyloid scan is a high possibility of Alzheimer's disease for the cause of the cognitive impairment. But the positive amyloid scan does not diagnosis of Alzheimer's disease. However, the differential diagnosis can be possible with the amyloid scan. After amyloid, there are 2 other radiotracer, Bijamil and Uracheck, get approval by FDA. And then recently in Korea, we have not FDA, we have one radiotracer to get KFDA approval for imaging of amyloid, that is Alzheimer. The characteristic is very similar with the other FDA approval radiotracer. They shows negative and the positive scan in the patient with cognitive impairment. In the clinic, so we usually use the kind of protocols. The radiotracer injection dosage around 10 millicurie, and the uptake time is a little bit variable. Some is shorter. Flupitabir can be acquired after 3 minutes after injection, but the flutometamol or probetabel needs more time to get imaging, around 2 hours. Propranolol, known as Alzheimer, the Korean radiotracer, is also have a short time to get the image acquisitions. After injection, after around 30 minutes after injections, we can get the imaging of the amyloid PET. Here shows the distribution of the amyloid depositions from the normal to the advanced Alzheimer's disease. The typical amyloid deposition in the Alzheimer's disease is located in the frontal cortex, lateral temporal cortex and the parietal cortex here, and then posterior cingulate areas. The frontal, parietal, posterior cingulate area, and then lateral temporal, the four regions are usually used for region of the interest in the quantification and the interpretation of the amyloid path. Here shows the negative amyloid PET scan using the fluorobeta band. In case of a negative scan, they show no abnormal uptake in the gray matter, and they were shown the white matter skeleton in the frontal lobe and the temporal lobe, and then the spear brain, which is a white matter retention of the radiotracer, but not in the gray matter. Here shows a positive scan using the fluorobeta band. And the similar finding can be seen in the fluotometamol, that means Bizamil. Bizamil also shows the four regions of interest, including frontal lobe, lateral temporal lobe, parietal lobe, and posterior cingulate areas. In case of the fluotometamol, they mention about the striatum. Actually, striatum is not included in the assessment of the RI, but the striatum is important. I will tell about you about the striatal uptake later. They show some more activity in the striatal result is a positive finding. They also the contrast use of a contrast between gray matter and the white matter area in the posterior cingulate area and the parietal cortex. Here shows a negative scan using the fluotometamol. They have a similar result with the other tracer, radial retention in the white matter skeleton, not in the gray matters. And then striatal area is blank, the photon defect. And then the positive scan also shows intense uptake in the cortical area, including frontal, parietal, posterior cingulate, as well as in the striatal area. Sometimes in the entire brain does not contain the amyloid pathology. Some has a limited area, show limited amyloid deposition in the temporal cortex or other parietal cortex. It also has a positive scan here. The small area of lateral temporal cortex or the frontal temporal cortex, we usually classified as a positive scan. The Alzheimer also the similar result. And then Alzheimer also similar progression of the amyloid depositions, and then starting from the parietal posterior cingulate area and the frontal cortex area. Like the fluotometamol, the Alzheimer also shows the striatal uptake in case of the positive amyloid scan. Unlike other tracers, it shows some more prominent in the hippocampal area, which is a contrast to the normal brain, but the hippocampal uptake is more prominent in the Alzheimer imaging. But the hippocampal uptake is not related with the tau pathology. Usually, the hippocampus is tau abundant pathology in the Alzheimer rather than amyloid, but this uptake does not relate with tau uptake. It shows amyloid specific fluorophenols uptake in the pathology in the autoradiography. Here shows a few cases of from the clinics. This patient is 6 years old, and they have a 3 months major depression history, and then the patient complained the subject to memory impairment. Doctor have 2 discriminations from the pseudo dementia from the MDD and mild cognitive impairment or Alzheimer's disease. Here is a patient brain MRI. There is no specific finding in the brain MRI. The brain atrophy is not typical, and the hippocampus is well reserved. And then, but their cognitive function is decreased. So this person is the cognitive impairment of this person is from the depression or the Alzheimer pathology. We have to the fluorobeta imaging. Before the retention imaging, we have to get the initial phase imaging, which reflect blood flow imaging, and very similar with glucose metabolism. In the initial imaging shows the well-preserved brain blood flow in the parietal, in the frontal temporal area, which usually involved in the neurodegenerations. So the early phase imaging is very okay. And then so the other session is also good. After 2 hours later, so we can get the amyloid PET imaging. So you see the radiotracer is localized in the white matter area, in the frontal parietal white matter, periventricular white matter, and then external capsules and show. But there is no amyloid uptake in the cortical area, the parietal or temporal or frontal or striatal areas. So we decide that this amyloid scan is negative for the amyloid. So the patient cognitive impairment comes from maybe their depressive symptom. There's another color scale, which is the same result. You may notice the striatal is empty because there is no amyloid deposition in the striatum. Lateral temporal is lower than white matter, as well as parietal lobe, and then posterior cingulate areas. Another case, the patient was 65 years old female. She is memory impairment, in particular recent memory impairment. She does not recognize their breakfast meal. She ate or not, and then she does the repetitive behavior, and then so there's some kind of a behavior change. The brain MRI shows mild brain atrophy in the cerebellum fissure area, and then so some white matter intensity, which means small vascular lesions, but the hippocampal size is well preserved, But the amyloid PET scan shows diffuse amyloid uptake in the parietal cortex and the frontal cortex, as well as lateral temporal cortex. We cannot discriminate the white matter activity from the gray matter activity. This was positive amyloid scan, and then the patient symptom comes from the amyloid pathology. Another case I want to show the vascular dementias. The patient has several years ago cognitive impairment. MRI shows MRI show typical vascular lesion in the subcortical area. They shows the white matter intensity in the white matter area. And then, like other amyloid studies, we do the amyloid, we do initial imaging to get the blood flow data. There shows a little bit decrease, but not typical Alzheimer patterns in the parietal cortex. And then the amyloid imaging, they shows the uptake in the parietal and the lateral temporal cortex. In case we do the the patient has combined clinical disease, vascular dementia with Alzheimer pathology. The same patient with a different scale and then different colors, we see the intense uptake in the lateral temporal and the parietal cortex. So that has a positive amyloid scan in the vascular problem. In case of the old ages, they are lots of the cases are comorbid with Alzheimer's disease and the vascular dementia. So we have to do, if patient have vascular lesions, we have to decide the Alzheimer patient is coexist or not using the amyloid PET. I will move to another case again. And finally, just to look around their diagnostic accuracy, this data was, this reported data was from the FDA approval document. They reported the sensitivity and the specificity is around late 80% to 90% to detection of the amyloid pathology in Alzheimer's disease. So usually in the clinics, we have to not do the amyloid PET scan in all patients with Alzheimer's disease. Usually we do the appropriate criteria for amyloid PET. The patient has
Hello.
Yes. Okay, so usually amyloid PET was performed atypical condition in case a patient was complained subjective cognitive impairment. The typical Alzheimer's disease case, the amyloid PET is not important because already they typically presented clinical and then typical disease progression. So amyloid PET is not important in that case. We usually, amyloid PET is usually used the atypical case. That means persistent or progressive unexplained memory impairment, and then the possible Alzheimer's disease, but the atypical clinical course was shows in the patient, and then the patient who have atypically early onset dementia symptom, they have to recommend the amyloid PET to evaluate the patient. But as like mentions, the core clinical criteria met the probable Alzheimer's disease, we do not have to do amyloid PET. Usually amyloid PET was practiced in the clinic, like these trees. If patient to visit clinic with objective cognitive deficiency and then symptom was atypical, while the age onset is very earlier, or rapid progression or atypical associated feature combined, they usually recommended the amyloid PET. So after the amyloid PET, we usually, the diagnosis of Alzheimer's disease is much easier, and then the amyloid PET added the diagnostic value of the Alzheimer's disease. In case of a before and after scan, they changed the diagnosis about they changed some cases change of diagnosis or diagnostic confidence. After the amyloid PET, diagnostic confidence is increased, and then some changes, some has diagnosis changes from the negative amyloid PET to other patient. Negative amyloid was defined as non-AD, and positive amyloid PET defined as AD patient. The percent of change is around 20% is amyloid diagnosis was changed after amyloid PET. So when we interpretations, we have the consideration of several factors. The first, the contrast for positive amyloid deposit. Usually we interpret the amyloid path. We compare the white matter intensity to gray matter intensity in visual assessment. And also, so we do the assessment with the cerebellar activity. Usually the cerebellum is used as a reference lesions, which was at least amyloid deposition in the Alzheimer's disease. And also we have to know about the patient clinical impressions, like underlying disease. The patient has have a family history, or the patient have a change of the behavior. Is the patient have associated symptoms such as depression or the movement disorder. And also the patient aging and the age of the onset is affected in the diagnosis or interpretation of amyloid path. And also apoE status was also important in amyloid depositions. And we have to usually correlate it with the MRI findings. The brain atrophy is very important. If a severe atrophy case, we are very difficult to evaluate the gray matter amyloid deposition in the path. So we have to evaluate their brain atrophy using the MRI. And also we have to evaluate the patient of the association of the vascular lesions, as we see the previous case. Usually PIB is gold standard for imaging of the amyloid path. So, but the other tracer, fluorobetabel or the protometamol was compared to PIB. The distribution is very similar, but the contrast is lower in the fluorobetabel than PIB or the flutametamols. The same cases of same patient, they shows the PIB path and the flutometamol or fluorobetabel. And then, so they have different white matter and the gray matter contrast. In case of the PIB, the contrast is more higher than flutometamol or the fluorobetabel. That means we can easily detect the PIB tracer than fluorine labeled radiotracer. But unfortunately, PIB is not good for the clinical practice because PIB is labeled was C11, so usually we cannot use it in the clinic. So we just do the fluorine labeled flutometamol and the bisamin, but we have to know the contrast is lower than the PIB. So the contrast ratio is about like that. Comparison the PIB is set at 1. The fluorobetabel is around 0.6. Flutometamol is around 0.7. That means lower contrast, and the beta peer amyloid is almost half contrast than the PIB. But usually the contrast, the distribution is very similar. But recently, the Navid tracer is more contrast than the flutometamol or fluorobetabel, but still is ongoing for FDA approval. RW is similar. The contrast is lower than the PIB. The contrast ratio is around 1.4, but similar distributions too. The age is one of the factors to prediction of the Alzheimer positivity. Usually the amyloid is accumulated during the aging. So the older persons cause amyloid positivity in healthy non-demented person, as well as that means underlying background is higher than the young people. So the positivity detection of the positivity is lower. The contrast of the young age, early onset Alzheimer's disease under 60, they have the positivity is very high, over the 95%. So the problem is Alzheimer's disease patients usually in the old age people, but the sensitivity is lower using the amyloid PET in older age. But as I mentioned about before, appropriate use of the PET is performed in case of the early onset cognitive impairment. So we have advantage used advantage when the young patient was evaluated. The amyloid PET in cognitive normal individuals, they as you can see, the amyloid accumulation positivity is gradually increased. But the slope is much higher, greater in the amyloid positive case, as well as apoE positive case. So apoE negative case, the amyloid positivity in the old age is a little bit lower than the apoE positive groups. So the amyloid positivity can affect age as well as apoE status. So apoE positive is highly vulnerable to the amyloid burden. So the amyloid positive case, we can get more positivity in amyloid PET, and then amyloid negative is a little bit lesser than apoE positive cases. And then the age factor, you can see the age factor also, 50s, 60s, 70s, 80s. The sensitivity is a little bit gradually decreased when the patient's age is increased. And the comparing apoE status, apoE positive group is a higher sensitivity in amyloid deposition using the amyloid PET compared to amyloid negative. So let's talk about the amyloid deposition in the striatum. When the flutometamol was approved by the FDA, they mentioned about the striatal uptake of amyloid tracers. But actually, the post-mortem study shows striatal amyloid deposition is reported in the post-mortem brain. This is Alzheimer patient and the normal non-demented age control autopsy data. The amyloid deposition in the cortical area and the cortex, thalamus, as well as putamen caudate nucleus and globus pallidum striatal amyloid deposition shows the Alzheimer patient have lots of the amyloid depositions in the cortical area as well as the striatal area. But the midbrain and then the pons does not have amyloid deposition. That means striatal region have lots of the amyloid deposition in the Alzheimer's disease, but sometimes we can see the image, the striatal deposition in the PET, or sometimes we cannot see the deposition in the amyloid PET. But the considerable amyloid deposition can be found in the autopsy data. So here shows normal negative amyloid PET, which shows the striatal blank. And then this is a positive amyloid PET, which shows the cortical uptake in the with the variable degree. And also they shows the increased uptake in the striatal area. That we call, we have cortical negative, striatum negative. This is cortical positive and the striatal positive. Some study shows the high striatal amyloid deposition is corresponded to disease progressions. In this study, they classified 3 groups according to the PET data. PET stage 0 means amyloid negative in striatum as well as cortical area. The stage 1 means only cortical amyloid uptake positive, not striatum negative, the stage 1. And the stage 2 means both striatal and the cortical amyloid positive. This classification stage 1, 2, 3, they shows different disease progression patterns. And also differential proportion is non-demented control, the MCI, Alzheimer's disease. Most control shows the PET stage 0, which means most control patient, control subject does not have amyloid deposition in the amyloid PET, but some has stage 1. Some shows amyloid deposition limited in the cortical area, and the very little portion shows stage 2. And then MCI, the portion is greater, and the AD patient, the portion of the PET stage 2 is much greater. So most AD patient shows stage 2 PET imaging, and some shows stage 1 imaging. Depending on the striatal amyloid burdens, the progression of the cognitive impairment is differently progressed in the MCI patient. Stage 0, which means no amyloid uptake. And the stage 1, the only uptake in the cortical area. Stage 3 shows both striatal and the cortical area. The stage 2 patient has rapidly progressed their cognitive dysfunctions, which is very correlated in other groups. The longitudinal PET study shows the correlation with the amyloid PET staging and their cognitive functions impairment. This is from the data of the ADNI as well. ADNI, and the follow-up study was around 5 years. According to the PET staging, the cognitive impairment progression rate is different depending on their amyloid deposit. In particular, striatal amyloid deposit is very important in their cognitive decline. As well as Alzheimer's disease, striatal plaque also predict concurrent of the Parkinson's disease in Alzheimer's disease. If a patient shows striatal amyloid depositions, some has Parkinson's disease is comorbid in the patient. If the is striatal positivity, the comorbid PDD is much higher and higher in the case of the amyloid negative in the striatum. So negative striatal amyloid depositions and the positive amyloid striatal deposition is differently distributed in the cognition and the Parkinson's disease. So last concept is amyloid PET negative in probable ADs. In the clinically, the doctors surely tell the patient is a probable AD. That means typical that the patient is typical AD, and we can maybe we can diagnose this AD in earlier. But the case of the typical AD, about 50 to almost 50 to 20% is amyloid PET negative. In case of the amyloid PET negative in the clinically well suspected of Alzheimer's disease, it is commonly seen in the older patient and the ApoE4 negative patient. So which we shows already the age effect in the amyloid positivity. Although patient has low sensitivity using amyloid PET, the amyloid PET negative is commonly seen in the older patient. And also ApoE4 status can be affected by the patient amyloid positivity in amyloid PET. That is mixed effect age-related pathology is most common. And also the possible false negative result caused by technical issues or scan misinterpretation, and then sensitivity is very low. In particular, the brain atrophy is most severe, very severe, so we cannot estimate the gray matter amyloid PET, sometimes with interpreted as amyloid PET negative, but actually that was amyloid deposition in the very atrophied brain cortex. But there is a possible true negative cases. The possibility is the patient was not properly diagnosed as Alzheimer's disease. Actually, the patient has other non-Alzheimer's disease pathology, but the clinician diagnosis as probable AD. And also, even though the patient has Alzheimer's disease, but the amyloid positive Alzheimer, negative Alzheimer's disease have different characteristics from amyloid positive Alzheimer's disease. That means amyloid negative Alzheimer's disease have different clinical progression, usually less progress compared to amyloid positive Alzheimer's disease. So the case from the Korea, we have lots of the Alzheimer's disease data. You see the amyloid negative percent in the Alzheimer's disease is around 10%. The 10% amyloid negative Alzheimer's disease was included in our Alzheimer's disease clinic. But the clinical diagnosis matched for the AD diagnosis. The amyloid PET negative is affected by ApoE4 positivity. And there's amyloid negative Alzheimer's disease. The age is a little bit younger, a little bit older, and then ApoE4 positivity is a little bit lesser than amyloid positive AD. And then the MMSE score is higher in the amyloid negative Alzheimer's disease than the amyloid positive Alzheimer's disease. So when we re-evaluate amyloid negative Alzheimer's disease, so after re-evaluation of the amyloid PET, they still remained as probable AD, but sometimes the patient was diagnosis was changed into frontotemporal dementia or other dementia. So the 50% is misdiagnosis when cases of amyloid negative Alzheimer's disease. But still, amyloid negative Alzheimer's disease exists. If we do the long-term follow-up of amyloid negative, they are usually cognitive decline is very slower than amyloid positive. So longitudinal change of the amyloid deposition and cognitive functions, comparing the amyloid negative and amyloid positive, the amyloid negative is a little bit lower, slower, and even no change or increased cognitive functions after long-term follow-up. In contrast of amyloid positive, progressively progressively decrease their cognitive function, and then their and then rapidly progression their cognitive function in the memory and the verbal fluency. So I'm just a summary. So amyloid PET is now clinically used. Then they can be added information to diagnosis, and then diagnosis confidence, and sometimes it change diagnosis of dementia patient. In particular, the patient has atypical presentation or the cases of early onset dementia, amyloid PET is very important. And then the amyloid PET is also impacted in the when the doctors, the confidence is lower to diagnosis of the Alzheimer's disease. So the Alzheimer's disease evaluations, now the amyloid PET is established for the Alzheimer's diagnosis. So I will continue the tau imaging in the next time. I want to break time for 10 minutes. And then if you have any questions, you can leave a message, or so you can ask me now. And then, so we're gonna continue 1:15, okay? Is there any question? Just to leave your question on the chatting site.
Okay, thank you.
Dr. Priska leave the question, what is the most common feature that we usually find in Alzheimer's diagnosis? I'm confined to amyloid PET. I already mentioned age is important thing, and then also the brain atrophy is one of important thing to detect amyloid positive, because severe atrophy interferes the interpretation of amyloid deposition in the gray matter. And then sometimes technical issues. Sometimes the tracers which is using currently, the tracer is labeled by the fluorine. And sometimes they shows the skull uptake or a scalp uptake. So I don't know why the scalp uptake in the fluorine agent, but sometimes the scalp uptake. And the skull or scalp uptake is make artifact in quantification of the gray matter uptake in amyloid PET. And then like that. Any question? Please leave your questions. I will be back 10 minutes later. Everybody is back? Yeah, so during the break time, there is no more question for the previous lectures. I continue the lecture for tau PET imaging in the Alzheimer's disease. I hope that you are all back. And likewise, amyloid targeting radiotracer, the ideal PET tau trace is common characteristics to entering into the brain, the binding specific target, and the imaging with the good imaging with a good time is important. So the radio targeting is tracer targeting, the high permeability and the appropriate lipophilicity is a principle, and also the rapid clearance and then low metabolism, and then the metabolite should not re-enter into the brain that makes a clear imaging. And also low non-tau targeting binding to other CNS receptor and tissue also increase the contrast. Actually, fluorine-labeled FDDMP was developed as the imaging of the amyloid, and however, they also shows the tau accumulations. The FDDMP shows the both amyloid pathology and the tau pathology. So this is the first tau tracer developed. Currently, there are several radiotracers, C11 labeled or the fluorine labeled THK compound, as well as the fluorine labeled T compound. And then recently, the more improvement of the radiotracers, the second generation tau targeting radiotracer is under development. The comparing to the amyloid path to imaging of tau pathology is more challenging. The first of all, unlike amyloid pathology, the tau pathology is a cause. The initial tau pathology was occurred inside into the cell. So that means that the imaging tracer should be entered into the cell. So the brain permeability as well as the cell permeability is important. Furthermore, the tau and then amyloid is very similar in their secondary structures. So the structure similarity and the richness of the beta sheets make harder to make a radiotracer to have a specific target for tau. And usually tau fibril is the affinity is lower than amyloid amyloid pathology shows. That means we need more specific, more high affinity radiotracer was needed. Furthermore, the tau fibril has several isoforms and also constructed these different structure, the 3D structures. The human tau gene has the 14 exons, and then there exists as 6 isoform of tau, which is differs by the splicing areas. Some has 4 repeated, or some has 3 repeated. So that depends on the type of tau protein, and it depends on the 3D structure, depends on isoform. The tau tracer has a different binding affinity. So, and also the ratio of 4 repeated and 3 repeated ratio, it was difficult to make a binding to the tau in the brain. There shows tau pathology in the brain biopsy. With the same tau promethylopathy, they shows the different pathology patterns. Some shows astrocyte tuft, some has like a thread, some has neurofibrillary tangles. Any tau specific target satisfied to binding all kind of specific all kind of tau pathology, but some is a more specific target for the tau tangle, or some is more specific to the fibril, but some does not differentiate. So we have to know about the characteristics of tau tracers. And depending on tau isoform and structures, there is several tauopathies. Usually, the Alzheimer disease we discuss in this lecture. They have 4 repeated, 3 repeated tauopathy, even ratio. But the PSP is mainly 3 repeated tauopathy, and then the CBD also 4 CBD, PSP and the CBD usually 4 repeated tauopathy. And the frontotemporal lobe dementia, they usually have the 3 repeated tauopathy. So some radiotracer is binding to the 4R, but some does not in 3R. And also the pathology usually comorbidity with the other pathology. In Alzheimer's disease has the amyloid pathology as well as tau pathology. Sometimes Lewy body pathology, that means synuclein pathology, also has a comorbidity with the tau pathology. And these different proteinopathy has similar secondary structures that may interfere with the binding of the radiotracer. So summarize the complexity of tau PET imaging. Tauopathy with a different clinical phenotype and pathology that requires different PET tracer with a different selectivity. And we are discussing about the off-target binding in tau imaging, and then we are discussing about the different other pathology markers. Radiotracer, several radiotracer for tau targeting tracer has been developed. Usually the upper low we call the first generation tau tracer. The lower column we call the second generations. The most famous is AV51, which is called the flutasipir. Currently, this is the only FDA approved radiotracer for tau target. And also, so we have to know about the characteristic of the THK compound, which is lots of the data with the THK compound. The C11 level, the PBB is very promising, but the limitation of the C11, so the data is not much. So we are in these lectures, I'm usually use the flutasipir data as well as THK compound data. This shows moderate lipophilicity for the entering of the brain, and then they have good selectivity over amyloid beta, and then the brain uptake is fairly good, and then the timing is good for the imaging, but some has radioactive metabolite which re-entered in the brain in case of a PBB. So we not talk about the PBB in this time, and then the white matter binding is a little bit different from radiotrace to others. The flutasipir is, as you mentioned, is the only FDA approved radiotracer for tau target. It has discriminatory binding to the tau pathology in the hippocampus in the parahippocampal area. The highly which target is highly phosphorylated tau fibril, which shows in typical Alzheimer's disease. T807 is more favorable characteristics, so currently the T807 is existing currently used. T808 is not further studies after that. Here show the imaging of normal subject and then the patient with mild Alzheimer's disease. As you can see, tau pathology was seen in the lateral temporal and the medial temporal and hippocampal area, as well as frontal cortex and the posterior cingulate areas. In comparing with the normal controls, Alzheimer patient shows high uptake in the cortical area, in the lateral temporal, in the parietal, in the medial temporal cortex. The clinical data was published in 2012. After 10 years later, around 10 years later, FDA approval was get. This slide shows the uptake of T-tacipir is correlated with the severity of the Alzheimer's disease. Increasing of the severity, tau uptake is greater in the temporal cortex as well as lateral parietal and the frontal cortex. So the tau accumulation in vivo imaging can be visualized at the Braak staging of the tau pathology. In the autopsy data, they have classified the Braak staging 0 to 6. The 0 means there is no tau pathology in the brain, so which is normal. And the Braak stage 5 or 6, the tau distribution is widespread of tau distribution in the cortical area, which is a full-blown tau pathology. In the tau PET can imaging this kind of Braak stage, no uptake, the medial temporal uptake in Braak stage 1, 2, and the medial temporal and lateral temporal deposition presenting Braak stage 3 or 4, entire cortical uptake presenting Braak stage 5 and 6. Let's see the coronal imaging. The tau spreading starting from the hippocampal, medial temporal cortex to starting from the hippocampus or medial temporal cortex, which was spread to the inferior temporal, lateral temporal, and then the more spread to the upper cortical area and the posterior cingulate. According to their spreading, so we can estimate the Braak stage in vivo imaging, which is well correlated with the autopsy data. So as I mentioned, tau and amyloid pathology imaging in vivo using the PET is well correlated with the autopsy data. However, tau is more correlated with the functional status. In the case of the tau PET, is well correlated the semantic function, visual spatial function, or global cognitive function with the tau deposition in vivo imaging than amyloid imaging. The TH compound is also developed in Japan, and then they well discriminated cortical uptake or hippocampal uptake between Alzheimer's disease and the normal control. And there is that was quite promising Radiotracer for tau imaging, and they shows typical uptake in the Alzheimer's disease. There was a different distribution of with the PIB, which means they shows a very specific binding to the tau. And in the human study, they also shows the difference between the healthy control to the Alzheimer's disease. The Alzheimer's disease, the uptake is localized in the hippocampal area, inferior temporal cortex, but not in the healthy control. And they shows the well demarcated in the TH compound, both TH compound. However, there is some critical issue in the THK compound. THK compound shows critical off-target binding issues. The off-target binding means there is another another binding site beyond the tau pathology. The MAO-A, MAO-B is widely known for the off-target binding in tau PET tracers. Actually, basal ganglia and thalamus is less pathology in the tau, but high uptake was seen in the THK compound, and as well as some shows in the the 4051 plutocybin, which is derived from the MAO-B uptake, I think. And then the distribution is basal ganglia is prominent activity of the MAO-B activity, and the midbrain, thalamus, and the hippocampus also has several activity of MAO-B. In this area, there is lots of the radiotracer, but not targeting to the tau specific, because the kind of activity can be found in the healthy control as well as Alzheimer's disease. For the proof of off-target bindings, they tried the diphrenyl hydrochloride changing. Diphrenyl hydrochloride is a selective MAO-B inhibitors. That means they inhibit MAO-B activity. Before the diphrenyl challenging, you can see the imaging of the Alzheimer's disease and control. The sample was taken from the striatum and the prefrontal cortex and the hippocampus. Comparing of normal healthy control, Alzheimer's brain has a high uptake with the THK compound in the cortical area, as well as the striatum and the hippocampus. But the control also shows the increased uptake in the striatal area, some part of the cortical area. After challenging of the diphrenyl, the uptake of TH compound is decreased. This is dose-dependent manners. Low dose diphrenyl inhibitions, high dose diphrenyl inhibitions is gradually decreased the uptake of radiotracer in the striatum. The reduction of the radiotracer uptake much greater in the striatal area than the brain cortex. The striatum is a very rich area in the MAO-B. So the MAO-B is one of the major off-target bindings. We can, the study demonstrate MAO-B is off-target binding, in particular in the striatum area. Off-target binding can be seen in the imaging of the in vivo imaging of the human. The disease study was was done by using the THK compound. This is a normal patient, amyloid negative MCI. This is amyloid positive AD, which we predict tau positive, and this is PSP amyloid negative or non-AD. So which also we can expect amyloid tau positive. In the amyloid negative MCI, we think this is negative binding, but we have the considerable binding in the basal ganglia in imaging of the THK compound, and less uptake in the amyloid. The selegiline is also the diphrenyl analog, which inhibit MAO-B activity. After administration of the selegilines, the nonspecific off-target binding is markedly decreased. The MAO-B is also demonstrated as off-target binding in THK compound. This finding is common in the amyloid positive patient as well as non-AD amyloid positive PSP. The basal ganglia is markedly decreased after challenging of the silagilin. And also you can see the imaging of the cerebellum uptake. The silagilin uptake challenging is decrease the activity of the cerebellum. The cerebellum, the MAO-B is not much, not quite rich, but the considerable MAO-B activity is exist in the cerebellum. Because of off-target binding in the cerebellum can affect quantification, because usually we use the cerebellum as a reference regions in the quantification as well as a visual assessment. So the off-target binding interfere the quantification of the target binding. So this issue can make use of the THK compound is limit. So the recently THK study is a little bit decreased. As I mentioned, the quantification data, the considerably lower quantification data shows after silagilin challenging, in particular basal ganglia and the thalamic area. Also, the decreased quantitative data in the cortical uptake in the Alzheimer disease, as well as control data. So when we compared with the THK compound, THK compound, which is high off-target binding for the MAO-B, and the flutaspir, this is known as a less off-target binding. They shows that off-target binding is very high in the THK compound, which contains the striatal area, and then as well as cortical areas. The comparing to THK compound and the flutaspir, the uptake in the basal ganglia is lower in flutaspir, which means a lesser off-target binding for MAO-B using the flutaspir than the THK compound. They also show amyloid positivity using the fluorobetaben. Frontotemporal dementia has different type of isoform for the tauopathy. It has this repeated tau isoform, which has a lower binding affinity with the flutaspir, but has high binding affinity with the THK compound. So depending on type of disease, depending on type of isotope form, we have to choose tau radiotracer. Off-target binding to the MAO-B is a major issue, but the other off-target binding is demonstrated in flutaspir imaging, in particular melanin pigment or the hemosiderin pigment or mineralization compound in the blood vessels. This is autoradiography using the AB4051, which is the flutaspir. They shows high off-target binding in the pigmented area, which was melanin pigment in the substantia nigra, which can be a normal structure, but was it can be binding with the AB4051. And also sometimes pigment containing lipofuscin or the vascular structure or the subpar melanin pigment can be attached with the AB4051. Is all the non-specific binding. And then choroidal plexus or the blood vessel shows a non-specific binding with the AV4051, which assumed as mineralization or hemostatin pigment. Sometimes, like as other fluorine-labeled tracers, fluotasipir as well as TK compound has off-target binding in the skull. The amyloid, the skull binding can sometimes interfere the cortical binding in the fluotasipir, which is sometimes shows, sometimes does not. The second generation Radiotracer, which is developing and which is trying to get the FDA approvals, they have characteristics of the less off-target binding to MAO-A and MAO-B. The AV4051 is a less MAO-B binding comparing to THK compound, but it has also considerable binding with off-target with the MAO-B activity. Comparing with the 51's, Yu Tracer MK6041 has a lower off-target binding in the entorhinal cortex or the cortical areas. So we expect this new tracer can be promising to reduce off-target binding. So comparing with the imaging of the human brain, there shows a different off-target binding activity. The MK compound or a new compound or PO or RO compound has a less off-target binding in the basal ganglia. So there is a little uptake in the basal ganglia comparing of the fluotasipir. The fluotasipir shows the basal ganglia as off-target binding and also shows the choroidal plexus in the ventricle is off-target binding. But the new tracers does not show the kind of off-target binding. But also it shows the well-contrast tau pathology in the cortical area in the new trace as well as the fluotasipir. However, still the off-target binding in second generation of target tau PET tracer was observed. Likely, fluotasipir's it binds to the melanin pigmentation or hemosiderin pigmentation or mineralizations using the RO compound or the MK compound. So around the endothelium in the vessels or the melanoma, metastatic melanoma also shows the tau PET tracers, which is off-target binding to the melanin pigment. Like a fluorine, other fluorine tracers, which also shows the skull uptake like that, which is also interfere the quantification of the tau tracers. But generally, it is well correlated with the tau pathology with the tau tracer uptake using the new tracer or the fluotasipir. They show so well correlated in the uptake tau fluotasipir, which already FDA approval tracer, and the new tracer RO compound, which was well correlated. And it shows a similar pattern in the cortical and the hippocampal areas. Comparing of the off-target binding, the new tracer is much lesser in the basal ganglia as well as the choroidal plexus. So which is more advantage when you use the imaging of the human brain. Nevertheless, there shows high diagnostic accuracy using fluotasipir. Finally, 2012, the FDA approval of fluotasipir approved as a tau PET imaging tracer by FDA's. Before the approval, state has accumulated multi-center tau PET study result, diagnostic accuracy, and then correlation with the cognitive symptom. They showed clinical data. In the multi-center trials, they included Korean data, almost 200 cases, as well as American data, and as well as the Australian data. They shows comparing to control the MCI to Alzheimer comparison. They shows high uptake in the Alzheimer disease patient in the cortical area as well as hippocampal area. With the lesser degree, MCI shows also high uptake than the control. And also the PPA as a variant of the Alzheimer's disease, high uptake in the cortical area, which is discriminated from the control. Using the tau pathology imaging with the PET, the diagnostic accuracy and the sensitivity is very high. This shows the using the tau PET accuracy, using the temporal ROI, inferior ROI, the main target is almost, the sensitivity is almost 95% and specificity is almost 90%. And the MRI is a little bit lower than the tau PET imaging. So the tau PET is quite promising. They shows quite a promising accuracy in detection of Alzheimer's dementia versus non-AD dementia. And then tau uptake is well correlated with the FCG metabolism on FCG path, also which is inverse correlated with the PIB uptake. So FDG, the metabolism measured by SUVR is well correlated with the fructose uptake, which is inverse pattern, and also the FDG uptake and then the PIB uptake, or the PIB uptake and fructose uptake is correlated, but the distribution is very wider, which means a little less correlated with the between AV fructose between FDG uptake. In particular, tau PET pattern is well reflected cognitive impairment. In particular, they shows their function of the memory, their function of the visual spatial, their function of the language, and the distribution of regional distribution is well reflective of their specific functions. Here shows the hippocampal uptake is well correlated with the memory functions. The occipital uptake is well correlated with visual functions. The language problem is correlated with the cortical, lateral cortical uptake of the tau PET, which is reflect specific cognitive function. However, the cortical uptake is not much correlated with the specific function with the tau PET. PCA, posterior cortical atrophy, is a kind of a visual variant of the Alzheimer's disease, has shows the progressive decline in visual spatial, in particular visual spatial functions. Usually the patient was calm, they have to discriminate it from the PCA from the DLB. But they shows the structural MRI and FCG PET, the PIB imaging shows the kind of abnormality. Actually, the MRI does not show the specific abnormality, but they shows the predominant atrophy in the posterior brain. It's quite suspected PCA. FDA shows the hypometabolism in the posterior brain. The PCA, both finding can suspect the PCA. However, the PIB uptake is quietly distributed in the wide spread of the cortical uptake, which was not differentiated from the typical Alzheimer's disease. The PIB imaging shows the positive, but does not show any further information. Comparing between the control data, FCG Path and the tau PET shows the region-specific uptake or region-specific metabolic decline shows, which means the tau PET can be show the clinical symptom-related patterns. However, the PIB targeting the amyloid pathway does not provide any information for the regional distributions. So target the superiority of the tau PET over amyloid is it can make the patterns related with clinical and the neuroanatomical variability in the Alzheimer's disease. We already showed the posterior cortical atrophy, which limited in the posterior brain and then decreased metabolism, as well as tau pathology in the posterior brain. And the locopenic variant of progressive primary aplasia is usually affected in the frontotemporal cortex, which caused the verbal problem. And the tau pathology is well located in the frontal and the frontotemporal areas, which having a lower in the verbal functions. The typical amnestic Alzheimer's disease usually combine the memory impairment, which in which the pathology is localized in the medial temporal and the inferior temporal cortex. And then corticobasal syndrome is another non-AD pathology, which shows that for repeated tauopathy has generally increased in the cortical area, which was studied with the fluticasone, as well as using the THK compound. They show similar findings, regional distribution, mirroring clinical variability in the Alzheimer's disease. So remind the superiority of the tau PET can reflect clinical subtype of Alzheimer's disease or other specific tau pathology. See again, FDG and FDG shows the region-specific metabolic decline, which reflect the clinical variant of the Alzheimer's disease or memory impairment. However, the amyloid pathology does not show the clinical regional and neuroanatomical correlations. Let's talk about the other than Alzheimer's disease. Alzheimer's disease has the tau pathology as well as the amyloid disease. However, frontotemporal dementia, progressive supranuclear palsy, corticobasal ganglia degeneration also has tauopathy, which has a different tau pathology in isoform type or the structure. However, the tau pathology can be make a tau specific tau binding using the tau PET. This shows typical cases of the non-AD tau pathology. The Alzheimer's disease typically inferior temporal and then the hippocampal area, the started tau pathology, which is related to memory functions. CBS, corticobasal degeneration, is usually related with the cortical tauopathy as well as midbrain tauopathy. PSP is more importantly is pons and midbrain as well as basal ganglia is a major target of the tau pathology. Another study also shows the different patterns of tau pathology in the tau PET. amyloid Alzheimer disease shows cortical tau pathology, also the hippocampal tau pathology, and the PSP shows increased basal ganglia, and then control has a little off-target binding in the basal ganglia. In particular, PSP is important because PSP sometimes does not discriminate from the Parkinson's disease. However, with the tau pathology, we can easily differentiate it from the PSP from the Parkinson's disease when the patient with complain the movement disorder. Discriminated accuracy using the tau PET for the Alzheimer's disease and the other neurodegeneration is quite specific. The Alzheimer's disease shows cortical uptake, in particular inferior temporal cortical uptake is very higher, and then depending on type of clinical variant, sometimes this shows the lesions in the frontal cortex, or sometimes shows the parietal cortex. But the other non-AD tauopathy, there is limited uptake in the cortical area, but shows in the other area, in particular basal ganglia. Discriminations Alzheimer's dementia from the non-AD, the sensitivity and the specificity is very high, and we can usually use the differential diagnosis of the dementia. In particular, they having movement disorders. I'm just added about the PSP imaging using the tau PET. As you can see, PSP may increase uptake in the basal ganglia in the tau PET. Comparing of the control, you can see increase of the basal ganglia uptake as well as hippocampal uptake. But we mentioned before, the basal ganglia is one of the part of the off-target binding for the MAO-B. So some accumulation of the tau tracer shown in the normal control. However, considerably high uptake in the PSP patient, but not PD patient. The usually PSP progression was originated from the middle brain and then increased to the middle brain and increased to the thalamus and the striatum. And after they spread into the cortical area. So the early stage of PSP can affect it in the striatal area as well as midbrain. Here shows the comparison study of the fluticasone in PSP patient and the Parkinson's disease. Comparing with the control, the PSP shows a high uptake in the basal ganglia, as well as comparing with the Parkinson's disease, which is a similar movement disorder. PSP has higher uptake in basal ganglia area. So this finding can be discriminated from the Parkinson's disease as well as Alzheimer's disease. And this shows the gradual increase uptake in the putamen and the striatal area in the PSP area. Fluticasone SUVR is compatible. Sorry. 네. 네. Comparatively, this high SUVR uptake in the PSP case. Just before mentioned, the PD has degeneration in the substantia nigra. And the substantia nigra has a high melanin component. So the degeneration of the substantia nigra, which means decrease the melanin non-specific binding. So comparing with the PSP, PD shows a lower activity in the substantia nigra, which can be seen in the imaging. Comparing the healthy control, the Parkinson's disease shows a lower uptake in the substantia nigra, which is not related with the tau pathology, which is related with the melanin binding non-specific melanin binding. But the non-specificity or the off-target binding in the basal ganglia, still there is no study showing the correlation with the PSP severity and tau binding in the striatal areas, because lots of components is related with off-target binding. So we have to solve this problem further. To the summary, the first lectures I was mentioned about the amyloid path. Now the amyloid path is well established in the management and then diagnosis of the Alzheimer's disease in the clinical. And then also it was tau path is a good biomarker in this management of the Alzheimer's disease. Tau PET in particular, there has a superiority over the amyloid PET, which can reflect the clinical symptom and the clinical cognitive function specific regional distributions. However, off-target binding in the tau PET, it should be improving for the imaging of tau PET imaging. The further study was needed, and then Radiotracer overcoming off-target binding is being developed. I think this is the end of my lectures. Please do any questions.
Professor Kim,
Yes.
This is Lee. I was listening to your the very succinct presentation. However, the entire field is a little bit complicated. So would you please summarize incorrectly? The first one is amyloid PET. According to the FDA recommendation or the expert recommendation from the United States, amyloid imaging is recommended to exclude Alzheimer's disease. And sometimes the amyloid plaque imaging is going to help to enhance the confidence that the patient had the Alzheimer's dementia based on the symptom, the observation. Or previously, we remember very well, just a decade or 2 decades ago, only according to the DSM criteria, only the symptom, the complex of the symptoms were the criteria to diagnose the patients having Alzheimer's disease or not. That was a probable, definitive is just biopsy proven and probable and possible. And the sooner or later there came to be a mild cognitive impairment, and then converter and non-converter issues were the hot topic. However, after almost 20 years after the introduction of the C11 PIB imaging, now we can say that if you are not quite sure that the patient would have Alzheimer's disease, then do the amyloid plaque imaging. So consisting of 4 radiopharmaceuticals or the radiotracers. In this country, and however, globally it was 3. So is this summary is correct for your first lecture, the first part of your lecture? Or
Yes.
if you have any more just kind of additional comment. Why? Because at the end of this lecture series, usually Professor Seo would have summarized and then made and confirmed the questions. The kind of questions and then answers. That questions were sometimes descriptive, but usually it's kind of the multiple choice. So if this is correct, then this can be converted to a question for the first part of your lecture, and then will be given to the participants. So at first, please say that my summary is correct, and then if you have any more information in addition to my just a kind of a crude summary, then please add.
Okay, so the first ones in the clinics, now amyloid PET is very established, so that it is a critical tool to diagnosis of the Alzheimer disease or the dementia. So when we diagnosis of dementia, the first thing is the exclusion of the other disease, organic disease, which usually done by the structural MRI. So the people comes with memory impairment or the behavioral change. The first to have to first is the structural change. Is there any tumor or the vascular lesions? The MRI is important, but at that time they do not evaluate the brain cortical atrophy. After exclusion, the kind of organic problems, they should evaluate what kind of dementia. So at that time, the amyloid PET is the core diagnostic tool now. If the patient has subjectively proved their cognitive impairment, which was tested by the neuropsychological test, the doctor recommended, and then so the recommended amyloid PET now. This is agreement in the USA, and then so recently we are also discussed about the medical care for the amyloid PET in Korea, so which is the consensus in the nuclear medicine as well as neurology. And then the amyloid PET is a critical tool when the diagnosis of the dementia. So the first thing, amyloid is now the critical diagnostic tool now.
Okay, so now I understand. Because even the normal subjects should have a highest or higher, in certain cases, higher uptake of amyloid the agents. So that has raised my skepticism since the birth of the C11PIB. That was the reason why I asked again after your comprehensive the explanation of the current status. So meaning we have three the options. One is the amyloid, another is tau, another the other is FDG. So previously we did FDG uptake, and according to your second part of lecture, interestingly, the tau uptake and FDG uptake, or clinical status of and the tau uptake hasn't. They have had inverse relations. However, the amyloid uptake appear too early and persist. And that might be the reason why the amyloid uptake and FDG uptake does not have a very good correlation. Actually, according to your plots, the cited from the literature is saying their p-value is not the trustworthy. and the R value is the real R scale or R value is saying that there is no correlation between amyloid uptake. So that's the reason, another reason why in your first part, though it's an established tool to do the established discipline to do amyloid plaque imaging in the suspected Alzheimer's disease patients or the patients with dementia. So my question about the second part is just like the comorbid case you have emphasized that there is according to the MRI findings, there is a white matter changes, and then there are so many lacuna infarcts, and patients can be diagnosed as having a vascular dementia, but in case of the pure vascular dementia, there is no amyloid plaque uptake. So if we have amyloid plaque, positive amyloid imaging, then the patients can be diagnosed to have vascular dementia as well as Alzheimer's disease. That kind of comorbid cases are so frequent. So even though amyloid dementia cannot be treated successfully currently, just kind of with digital therapeutics, the only we can just kind of delay the progress. However, in case of the vascular dementia, there have been many recommendations to do the just kind of reverse the pathology, clinical the course. So the question is, how often do you see Parkinson's disease with dementia, or the cases of the non-AD dementia, such as the corticobasal degeneration or the corticobasal syndrome, or other forms of dementia, such as the TDP-43, or the ubiquitinopathy, or tauopathy, even post-traumatic encephalopathy related with the pathologic tau. So would you please add a little bit more? Why? Because there are so many the rare tauopathies which is have been not so familiar to the Nuclear Medicine Society. So that's my question to the second part of your lecture. Please.
Yes, so let's summarize well. The first of all, as Dr. Lee says, the amyloid can be positive in the old age because without the subject, without cognitive impairment. So in the clinic, the amyloid PET is meaningful if only when the patient has a subjective cognitive impairment was proved. That means the amyloid PET should be done after neuropsychological test, and then the test result shows the patient has the cognitive impairment or the functional impairment. After that, the amyloid PET data is meaningful. So that means if I'm healthy and I have no problem, but I want to do amyloid PET, if I have positive, that is not important. And we still know not full data for the meaning of amyloid positivity in non-dementia patient in currently, because theoretically they can be the amyloid Alzheimer's disease development 20 years after. But currently, the amyloid positive with the cognitive normal is not meaningful in the clinic now. So say again, the amyloid positivity means only means when the patient have proof of cognitive impairment by subjective test. And then they have a subjective cognitive impairment. Amyloid positive test was done. If the results positive, we think about the Alzheimer's disease. If the amyloid is negative, we have to find another reasons why the patient's cognitive impairments comes from. So we can do the tau imaging or the other study. The FCG Path also correlated with the tau imaging, and then they show the metabolic abnormality in the affected site. But the FCG is kindly indirect result of neurodegeneration. Excuse me, 여보세요? 네. 네. 조금 있다가 강의가 안 끝나가지고 10분만 기다리라고 해주세요. 네. 뭐 얘기지? Okay. The FDG is the indirect imaging of the neurodegeneration, as well as the FDG shows the hypometabolism by the very variable cause of the cause, such as depressions, which is not dementia, but the functionally depressed brain function. And then FDG also affected by the drug. So the hypometabolism of the FDG is quite time specific. It can be reversible, it can be disease state specific. So that was not specific for the neurodegeneration by the Alzheimer's disease. That's why we can diagnose this with the FDG only in the Alzheimer's disease. And then, so the comorbidity with the vascular disease is a very common in the old age. So we have, but some part is reversible, and then some part need the medication for the vascular region. And then, so we have to discriminate it with the Alzheimer's disease, which is irreversible neurodegeneration. And that's why we do the amyloid PET. Is one of your question, I think. And then I have not much time, so I want to answer your final questions. In case of the non-AD tauopathy, such as the PSP or the CBS or the Parkinson's disease with dementia. In Korea, I'm not sure about the global data, but in Korea, so currently the Parkinson-related disease is the incidence is gradually increasing. In case of our hospitals, which we have a special clinic in the movement disorder, they have cases, they refer the cases, 1 or 2 cases a week of PSP. They want to discriminate it between the PD versus PSP. They want to discriminate it the dementia versus movement disorder. PD is the most common movement disorder, but the PSP is not unusual currently in our movement clinic. So we have to more chance to see to meet the PSP case in Korea as well as our hospital. I think the other country, the movement disorder, including PD and PSP, is gradually increased because all this kind of disease is the incidence is increased with age. So we have to know about this kind of disease, and then we have to discriminate this disease from the Alzheimer's disease and then other movement disorder. Maybe the movement disorder itself will be lectured by the Dr. another Kim next time. And then I think the Dr. Lee, my answer is
Yeah,
enough?
For me, actually, I'm an outsider in the meaning that I do not see or I do not take care of the clinicians, and you are taking care of the clinicians who refer the PET imaging in your hospital, in your clinic. So the participants still remaining 61, and the students, you have collected a best summary of the current status, which was explained by Professor Kim. So you have another session, another lecture next week. So why don't you just begin studying? This field is quite complicated, even though my major is also brain. I don't understand very much. So please just start or begin studying based on the presentation materials, or preferably, if Professor Kim allows, that the explanation can be given to you. So after some the editing, so please start studying, and then next week and the 2 weeks after, you have the chance to ask questions. I know that the Alzheimer's disease related clinical practice is not frequently done in Asian countries. So this might be a quite good start. Thank you, Professor Kim. Professor Kim, you can just close. That was my just kind of recommendation or advice to the participants.
Okay, so for the full clinical practice, I will summarize 10 minutes to summarize in the next time. As we already discussed, that tau is not used for the clean now. So it is tau is maybe you may not have experience yet. And also the tau experience is very limited. I will summarize more focusing to the amyloid path.
Okay. All right.
Okay.
So yeah, then thank you, Professor Kim, and you have the right to close this session. Okay.
Okay.
Thank you.